And now I am going to welcome for the next lecture, lecture 1, that is the PALIC 2, what's new. It is the chairperson for this session, Dr. Professor Taraknath Ghosh. Next slide. For this session, we have the chairperson, Dr. Subroto Chakraborty. Sir, please come on the stage. I welcome you. And he is a consultant in Manipal Hospital, Salt Lake City, Kolkata. He was a former faculty and professor of pediatrics at Institute of Child Health, Kolkata. He was also the president of West Bengal Academy of Pediatrics in 2021 and national executive body member of Indian Academy of Pediatrics. Okay, so please. Now, I want to welcome Professor Taraknath Ghosh. He is another chairperson for this session. He is a professor and in charge in PICU and Neurodevelopment Clinic and also the ex-NICU in charge Department of Pediatrics in Bardwan Medical College. And for this session, we have our speaker, Dr. Anil Sachdev sir. He is, everybody knows him very well. He needs no introduction. Sir, please start.
Good morning, everyone. I have the privilege to introduce Dr. Anil Sachdev. He is the Director of Intensive Care Medicine and Pulmonology at Sir Gangaram Hospital and also co-chairperson of the Institute of Child Health, New Delhi. And we are going to have a very good session, and I was just listening to the interventions by Dr. Anil Sachdev. So now I hand over the mic to my chairperson to say a few words.
Okay. Acute lung injury in pediatrics is very much common in ICU practice in pediatrics. So there is there are no clear-cut guideline previously. Now it is streamlined with PALIC 2. Which is a protocol devised by certain expert from different parts of the world, and it is formulated, and sir will highlight it how do we manage these such cases. Thank you, sir. You start.
Thank you very much, Mr. Chairman. I want to thank the organizers for giving me the opportunity to speak on this very recent guidelines. We had been classifying and managing patients of pediatric ARDS following the adult guidelines, that is American European guidelines, and then the Berlin guidelines, till 2015 when we had the first pediatric acute lung injury consensus conference guidelines 2015 published in Pediatric Critical Care Medicine Journal, and following that, and that study was that guidelines were based till 2013 literature, and were primarily based on the pediatric studies. After that, 2015 to 2020 or 21, there had been a lot of research on the pediatric ARDS. Many new papers came, very landmark studies were published. And the other problem that was discussed and that was appreciated by the pediatricians all over the world, that there is no mention of the resource limited setting ARDS, because we have our own problems, and that is what has been addressed in these PALIC 2 guidelines. And of course, there was element of non-adherence and varying implementation of the PALIC 2015 guidelines. So in February 2023, PALIC guidelines 2 were published in Pediatric Critical Care Medicine. As I told you, 2012 literature was included till in 2015, and then there were panelists as per the publications in the last 5 years. 8 countries, experts from 8 countries, 27 experts were included, mainly from North America, Europe and Australia. And then further research has come, and the more publications were included, and more countries, like 15 countries experts were included, and that accounted for 52 experts, with the 4 methodology experts, and 1 implementation expert was also there. So this time they formed the committees. They identified 11 sections where they wanted to come out with the guidelines, and the most important and the last 2, that is the clinical informatics and data science, and the implementation in the resource limited setting. These were the 2 additions. So in each committee there were experts, like 5 to 7 experts were there, and with the 1 expert from the resource limited setting. So they came out with the guidelines. They used the grid, that is the recommendation, assessment, development and evaluation parameter, and research and development guidelines were also used. So they came out with the good practice statements, they came out with the research statements where the more research is required, policy statements and the definition statements. So first we'll talk about the definition and the epidemiology. So this is 2015 PALIC guidelines, and the non-invasive ventilation was included in this along with the invasive ventilation, and the ARDS was divided no more into ALI and ARDS. Now it is divided into mild, moderate and severe as the Berlin guideline, which is used in the adults. And the more important point was that over here, instead of the PF ratio, that is PaO2 FiO2 ratio, in these guidelines we used SF ratio, that is saturation, and FiO2 ratio, because in many pediatric patients arterial sampling is in a sick child is difficult, so that was included. And we in these guidelines there was more emphasis on the oxygenation index in ventilated patients than the PF ratio, because oxygen index takes into account the mean airway pressure. So that makes it rather more robust in a marker to assess the oxygenation. So this is the latest PALIC 2 guidelines. Over here, the difference is that the new opacities in the chest imaging in the parenchyma, and which were not primarily due to atelectasis or pleural effusion. This was not mentioned in the PALIC 2015 guidelines. And second is the SF ratio, which was 264 in the previous guidelines, is now reduced to 250, because they found that it did not affect the outcome or the management if we reduce, and 250 is easy to remember also. Now very important point is that over here they applied a time period of about 4 hours before the stratification of the pediatric ARDS. So this hypoxemia at 6 hours has been shown to discriminate better in the PICU mortality, and as you can see in the ROC curve, the 6 hours was significant area under the curve. So they thought that the 6 hours maybe have some operational problems, especially for the trial purposes. So it was consensus was to come down to the 4 hours of the initial stabilization part. That improved the mortality discrimination and minimizes the excessive treatment in these patients. The disadvantage was in severe ARDS patients, the possibility of delayed management was also thought of. So as you can see, the mortality on the y-axis in the at the time of onset, it does not give any information, but later on in the PALIC categories, on the mild, in the first 12 hours and 24 hours, there was a definite change in the mortality with the time. So this is, then the second is they combined mild and moderate. As compared to 2015, the mild and moderate category was combined into one. So now we have only 2 categories, mild, moderate or severe ARDS. Now it has been appreciated, you can see the OI and the mortality, the mild and moderate, there is not much difference in the mortality. So it is helpful in the easy to classify these patients, and it is away now, it is different from the neonatal ARDS or from the Berlin definition, where there are 3 levels of stratification. So you can see over here, this is home ventilation, this is non-invasive ventilation ARDS, then the mild category, the mortality is 12.4%, in the moderate is 10.3%, so there is no significant difference between the two, and of course the severe ARDS, the mortality is above 32%. So that is, these are the studies, on the basis of these studies, they have combined mild and moderate ARDS. And also in the resource limiting setting, if there is a possibility, all the other criteria for the pediatric ARDS are met, you don't worry, you treat this patient as a ARDS even if the X-ray is or the imaging is not available. And another point is that there is a addition of possible ARDS and at-risk ARDS. I will talk about that. So now there is new categories, that is the possible ARDS and at-risk ARDS. The possible ARDS is then so these are the 222 patients of pediatric ARDS. 50 were categorized as possible ARDS and 172 as at-risk ARDS based on the use of respiratory assistance devices. I will tell you what. So they found that out of 50, the 38% developed ARDS, and in the at-risk, the 16% developed ARDS, and there is a significant change. So possible ARDS is nasal continuous CPAP or bilevel pressure or high frequency ventilation, high flow ventilation with more than 1.5 liters per kg per minute, or more than 30 liters per minute. If a patient requiring this much of HFNC, then there is a possible ARDS, pediatric ARDS. So this is what it is. The FiO2 can be set on the HFNC, so we can have very reliable SF ratio, and pediatric respiratory failure is defined when the HFNC requirement is more than 1.5 liters per kg per minute, and the children who are requiring more than 30 liter per minute air flows, then they eligible for the ARDS. And the at-risk is when they do not meet the criteria for ARDS, but they require oxygen support to maintain saturation above 88%. So they are at-risk ARDS. So if you look at the interface, the IMV, full face NIV, nasal NIV, HFNC, so all these have been defined very clearly now. These are the studies on the basis of which the guidelines have come. So as you can see, OI ratio has been used, SF ratio has been used. So on the basis of this, we can classify our patient into PARDS, possible ARDS, and at-risk ARDS. So your perspective for the treatment changes. You are more alert, you have to monitor these patients very regularly. Now some bit about the pathobiology, severity, and the risk stratification. So one thing that they have added in the PALIC 2 is the monitoring of dead space ventilation. That ETCO2 is available to all of us. Blood gases we are doing, so you can calculate the alveolar dead space fraction, that is PCO2 minus ETCO2 divided by PCO2. So there are two ways to calculate or measure the dead space ventilation: if you have volumetric capnography or you have time-based type capnography. Time-based is easily available, it's less costly, and almost anybody who has the multi-parameter monitor can have time-based capnography. So the measuring the dead space ventilation has outcome benefits, or it helps in the stratification. So end-tidal volume space fraction, that is highly correlated with the alveolar dead space measurement and independently associated with mortality in acute ARDS. The drawback is if there is a lot of intrapulmonary shunting or there is a change in the cardiac output, so dead space ventilation will definitely change. So this is what is shown. Even with the OI less than 10 or more than 10, the dead space ventilation was significantly determinant of the mortality. So the other new thing that is added in the PALIC 2 as compared to 2015 guidelines, the identification of phenotypes. We also know that a patient of pneumonia with ARDS behaves very differently from a patient of trauma with ARDS, like polytrauma patient developing ARDS, or a pediatric patient or adolescent who comes with pancreatitis with ARDS. The behavior is very different. The outcomes are very different. So this is what is they called as the phenotypes of ARDS or endotypes of ARDS. Like in COVID time, we had few cases of hyper cytokine storm, which is now we identify very easily. So the patients who had hyper cytokine storms, they had higher mortality as compared to patients who had hypocytokine storm. So these are the identification of endotypes. So the emphasis now is on the identification of phenotypes and endotypes, and the identification of biomarkers which we can do in the ICU and identify the phenotypes and endotypes. So these are the different biomarkers which are, the research is going on, and still we don't have any answer. Invasive ventilation. Now the emphasis on 6 to 8 ml per kg, that we know it has mortality benefits, but anything less than 6 should be used only when your plateau pressure and driving pressures are guiding you. If you're at 6 ml per kg, your plateau pressure is going towards 28 or 30, then you need to reduce the tidal volume, or the driving pressure going above 15 or 17, then you need to reduce. Tidal volume below 4 ml per kg should be used with lot of caution. If you look at these graphs, the relationship between the plateau pressure and the mortality is like parabola. If you give very low tidal volume just to maintain your plateau pressure, the mortality is high. If you give higher tidal volume with high plateau pressure, of course the mortality is high. So if you look at the orange line, it shows driving pressure 27 with the respiratory rate of 30 and driving pressure 21 with a respiratory rate of 45. The mortality is very high as compared to where the driving pressures are low and the rates are low. So when you are ventilating patients, you have to, now it is a part of monitoring. Driving pressure is very easy to calculate. So it is a part of monitoring of your daily respiratory charting. Regarding the PEEP, level should be typically maintained above or at the lower PEEP higher FiO2 chart, which was used by ARMA trial and published in 2000 New England Journal of Medicine. Now the guidance is don't use 10 to 15 ml as guided by the 2015. Now it has been shown that the studies where the PEEP was lower than that grid, we call it FiO2 PEEP grid. The grid, there are two types of grid. One is high PEEP, low FiO2. There is low PEEP, high FiO2. So they are recommending to use low PEEP, high FiO2 grid for the setting setting the PEEP in the ARDS patients. So it has been shown the study in the centers where they used PEEP lower than the grid recommended level, then the mortality was high. So as you can see in this Kaplan curve, survival curve, the orange line is as according to the grid, and the blue line is lower PEEP levels, and there is at all PF ratios and overall also the survivals are different and significantly different. So insufficient evidence is there to calculate or use mechanical power. We all are talking about mechanical power. Yesterday there was a talk on mechanical power. So it is not recommended to calculate mechanical power at this point because the evidence is not very great about its utility in the pediatric ICU. There is no mention of high frequency jet ventilation or percussive ventilation or liquid ventilation. As long as this is again the evidence that mechanical power, there is some evidence that it is associated with mortality, but the pediatric studies are required. Ancillary pulmonary treatment, again steroids. We always talk about steroid. Child is not getting all right, give steroids. The 2015 they said steroids cannot be recommended as routine therapy, but in PALIC 2 they are very categorical. They are against the routine use of steroids, except in selective use of steroids in COVID-related ARDS. This is where some benefit has been shown, that too in many of the adult studies. So insufficient data for at least in children, so no routine use of steroids at all. Non-pulmonary treatments, they have included in the pulmonary treatment INO, that is inhaled nitric oxide, no evidence. Surfactant, no evidence, so not recommended at all. Non-pulmonary treatments, particularly in patients who are on sedation for more than 5 days, so the unit should have a sedation protocol and how to identify and how to handle iatrogenic sedation withdrawals. So that is very important, that we have to identify and make a policy of the unit. As you can see, opioids used for more than 5 days were related with the iatrogenic withdrawal syndromes. Similarly, benzodiazepines, if given for 7 to 10 days, were also contributed to the withdrawal. Delirium and sleep, very important aspect, and it is totally ignored in best of the units. So we have to do daily assessment of the delirium of these patients, non-pharmacological management like sedation in the night, like noise and light optimization in the unit, augmentative and assistive communication with the child, involve the family with the child care once they are on the weaning process, and mobilize the patient as early as possible. As you can see in this graph, in the ICU days on the x-axis and the delirium percentage on the y-axis, most of the children develop delirium in between 7 to 12 days of the sedation. Next is the blood transfusion. Child is not getting well, give transfusion. No, it is not required. A child with respiratory failure who has hemoglobin less than 5 is an indication to give blood transfusion, which was in the previous guideline was 7. Against the transfusion in critical ill patient, if the hemoglobin is greater than or equal to 7 with hemodynamically stable and does not have cyanotic heart disease. So these 7 is no more indication. You can ventilate your patient with the 5 level also. Sleep and rehabilitation I have already discussed about. Nutrition, start feeding as early as possible. Try to give minimum of 1.5 gram per kg per day protein in these patients, because the positive balance was seen, as you can see in this correlation graph, the positive balance is, protein balance is seen in patients who had protein more than 1.5 grams. Non-invasive respiratory support we have already discussed. So this is again time limited trial. Don't put NIV and okay, we'll see tomorrow. No, it cannot be done. So it has to be, you have to have a set time. So within 6 hours of NIV or non-invasive respiratory assist devices, you should make up your mind where you want to go. So again, this is corroborating the fact that within 6 hours it should be decided. As you can see, the green line is showing the failure and the dotted line is the success, and the failure you can come to know within 2 hours. If the patient is not responding to NIV or non-invasive respiratory device, you will come to know within 2 hours. So don't waste too much time. Then CPAP and HFNC in resource limited setting is very much desired, and it has shown in Africa, it has shown a better outcome even in cases of pneumonias. The use of bubble CPAP improved the mortality. As you can see, the diamond is in favor of non-invasive CPAP, HFNC, combination of HFNC CPAP, bubble CPAP, it is in favor of using the non-invasive ventilation. Extracorporeal VV ECMO is desirable as compared to VA ECMO with the cardiac functions are normal. As in the previous study, if you, in the panel discussion we said, if your patient is not responding and you anticipate use of ECMO, transfer to the ECMO center as early as possible. There is no recommendation on use of extracorporeal carbon dioxide removal. And very important is all these patients who are on ECMO should have neurodevelopmental and physical functioning evaluations on time to time. Morbidity and long-term outcomes, again, we have to check the pulmonary functions of these patients in the first 3 months once they are out from the ICU. Clinical informatics and data, this is basically clinician implement electronic tools to automatically screen critically ill patients to help identify those with PARADS or significant to develop at risk of developing PARADS. Developing region, resource limited, again I have already emphasized on this, use of non-invasive ventilation, treat possible pediatric ARDS as ARDS patient, identify at-risk patients and start HFNC or non-invasive ventilation. So this is the last slide. You can see the green is good practice statement, light orange is low evidence, very low evidence and moderate certainty. So there is no recommendation regarding recruitment maneuvers, high frequency ventilation or prone positioning, while for the use of bilevel NIV, HFNC in the depending on the SF ratio, oxygen index, once the patient is intubated, you have to stratify your patient according to that, and your tidal volume 6 to 8 ml, low tidal volume only when the pressures or the driving pressure or the plateau pressure are going above the limits. There is no evidence or very low evidence for inhaled nitric oxide and neuromuscular blockade. Thank you very much.
Thank you for the excellent presentation, sir. We can have some questions.
There are 28
one or two
references to
questions
this.
from audience.
There are 28 articles on, more than 28 articles on PALIC 2. So on which the basis it is done. Yes, sir.
Any questions? If there is no question, we can conclude the session. And again, thank you, Dr. Sachdev, for nice presentation and elaboration.